Oké, wacht hoor. Ja. Ik moet natuurlijk in het Engels praten. Dus ik begin eerst met een heel officieel dingetje. En dan mag je je even voorstellen. En daarna, ik druk elke keer weer op pauze. Zodat ik niet alles hoef te knippen en plakken. Ja? Oké. En er komt nu net een auto aan. Nou, geeft niet. Okay, so everybody, this is my dad. My dad is an orthopedic surgeon, and he has been very helpful in the process for me to find a surgeon and to give me all the information I need regarding a prosthetic hip and of course the procedures. So Dad, can you please introduce yourself and tell something about your work?
Okay. I'm Rolf Bloem. I'm an orthopedic surgeon, but retired from clinical practice 2 months ago, but still active as director of Orthopaedic Center. And my specialty has always been, and for which I still get consultations, by the way, hip problems, especially in the young adult hip. So I do a lot of arthroscopies and arthroplasties and revision surgery. That is my main topic.
Okay, thank you. So of course I have a couple of questions for you. And so first are a couple of general questions, and then I want to get into the questions that my followers have asked me to ask you and Professor Dr. Thala. So first of all, can you just give a brief description? What is hip dysplasia?
Basically, the hip is a ball and socket joint, as they call it. So you have a ball and a socket, and the socket is supposed to cover the ball in a sufficient way to make the joint stable. In hip dysplasia, the socket is underdeveloped, so that instead of reaching over the ball, over the hip, the femoral head of the head of the hip joint, it actually is too short. So it can cause instability. It diminishes the surface on the acetabular side, on the side of the cup, which buries the weight, which gives an increase of forces. Thereby, it can provoke early arthritis in the hip joint.
Mm-hmm. Mm-hmm. Okay. So basically, the cup is too small, and that is why it can wear down the cartilage faster.
Yeah, because if you look at pressure, it's force divided by the surface. So the larger the surface, the smaller the pressure. If you have a small surface, then you have a lot of pressure, and that can exceed physiological limits. Hence causing arthritis.
Okay. Okay. Is that something that people are born with, or is it something that develops? Because a lot of people have asked me, how can I prevent getting hip dysplasia or arthritis? But it's basically, I wouldn't say a birth defect, but it's something you're anatomically born with, right?
Yeah, but yeah, basically it's a developmental defect, as you put it. There's a familial tendency, so there are families which have high tendencies of hip dysplasia.
Can you please tell me, do you also have a prosthetic hip?
I have 2 prosthetic hips.
So in our case, it would be definitely
No, because I have different cause for arthritis.
Oh.
But you had a special position in the uterus during before you were born.
Okay.
And you were also so that kind of gives a higher risk of developing hip dysplasia. So basically what we do, if the children are just born, very young babies, within a week, we want to check them for hip dysplasia, or at least a luxable hip which can be put in and out of the socket. But it's something you are born with. And if you treat it early, if you recognize it early, it's very easy to treat. If you miss it, or it is subclinical, then it becomes very difficult to treat.
What is subclinical?
Subclinical means that you can't really diagnose it.
Okay, okay. And in my case, it was not diagnosed, right?
Yes. Yeah.
Okay, yeah. So because of people also ask me this a lot. Okay, so we've established that hip dysplasia is something people are born with. It usually gets detected at birth, not always, and it's basically a different shape of the hip joint, which causes, in my case, more pressure in the hip joint itself, which causes a faster wearing down of the cartilage.
Yeah, and some instability. Which
and
I
some
think
instability.
In your case is particularly important because you have this extreme flexible
range of motion.
Joints. Yeah. So if you have an unstable hip and you go beyond the limits which you would normally have if you would have a normal joint, then you might damage the hip even more.
So it could have been that if I would not have been practicing flexibility and pole in such an intense way, that I might have never noticed, or at a very late point correct. In my life. Yeah. Yes. So we can for sure say that me doing pole and flexibility has accelerated. Can I say accelerated, or the wear and tear?
Yeah, you really don't know whether or not if you wouldn't have practice this sport, you would end up with an arthritis. But I'm sure it didn't help. Also because the MRI we made from your hip joint showed that there's a certain ligament in the joint. It's called the ligament teres, which was absent.
Yes, so it was completely.
It was actually how it connects the hip head of the hip joint with the cup. So that was absolutely absent.
Completely wore down. Yeah. So I think with me, it was already at a stage that was a little bit further than. I think with most people, it might have been detected already earlier, maybe. Yeah.
But we usually see if we have patients with hip dysplasia, which was not detected in the child years, usually you see them coming in between, say, 20, 24 and 30, 35 maybe, and then they start having complaints, and then it may be diagnosed.
Okay.
And if you're early enough, then you can still do something else beyond a joint replacement. But you should do it before you see arthritis.
Okay, this is also an important question, because some people that are diagnosed with hip dysplasia also ask me the question, what can they do to prevent this problem? Should people with hip dysplasia completely stay away of all flexibility, or should they just moderately train? Is it always going to end up with a prosthetic hip or an arthroscopy?
No, it's not always going to end up with a surgery. I think excessive flexibility training, if you have a dysplastic hip, is not a good thing.
Guilty.
And I think
but I didn't know. In my defense, I did not know I had dysplasia.
Yeah. And you can also turn it around. Eh? You probably had the flexibility because you had this dysplastic hip.
Also an important question. Yes.
Yeah. So moderate flexibility, I think, is not a problem, but you also should always exercise the hip muscles, so the buttocks, the abductors, muscles like that.
This is what I do in all my flexibility training. So this is also, I think, a reason why I have recovered. My recovery so far, because I'm not fully recovered yet, but my recovery so far is going pretty well because my muscles there are very strong, and my my flexibility is mainly active flexibility practice. I think that also helps. Okay, so you basically also say it's not that people with hip dysplasia should not do flexibility training, or that they will always end up with prosthetic hip surgery. It's just in moderation, and it probably also kind of depends on the personal situation. No, it won't be the same for everyone.
Yes, and there are different degrees of hip dysplasia. You can have a severe dysplasia, or you can have a mild dysplasia. Usually the severe dysplasias are detected earlier. So around 20 years, you see people coming in and they're complaining of, and if you have a severe dysplasia, then I think flexibility training is unwise.
Yes.
But if there's a mild dysplasia, I think moderate should be okay, but you should be aware that if you get complaints, you should consult the doctor.
Yes. That's a very important message for everyone who is watching. If you have complaints, go to a doctor. But I think most people watching this video have already either spoken to a doctor, maybe even started the process, or are thinking about it, that's for sure. Okay, so let me think. I think that's like the first. Yeah, could you also just briefly describe what arthroscopy is? Because basically the first, like, what's the difference between arthroscopy and getting prosthetic hip, and in which situation you do which, basically?
Yeah, well, basically if you do a prosthetic joint replacement, total hip replacement, the joint is non-salvageable. It's gone. So to perform an arthroscopy in an arthritic joint has no sense, makes no sense. So
what is an arthroscopy? Let's start there.
Arthroscopy is a kind of surgery in which you make 2 or 3 portals, little incisions around the hip. You enter a scope, some optics, which you can see on the monitor inside of the joint. And you can use another portal to get some instruments inside of the joint and to do some surgery. But the kind of surgery you can perform with arthroscopic surgery is limited. So
it's basically the repair of the labrum, right?
Yes, labrum repair, and some other abnormalities such as cam and pincer deformities, which is pincer is actually the opposite of dysplasia. Cam is something more on the femoral side, on the thigh bone, but I think cam and pincers are not that important if you have dysplasia. If you have dysplasia, usually the labrum compensates. It's a cartilage ring along the edge of the cup. And if it tears, it will give you pain, and the labrum usually compensates for the lack of bone. So the body tries to find a compensation mechanism. So if there's a tear in the labrum, that is something you can repair, but only if the dysplasia is not too severe. Because if this dysplasia is severe, you should perform surgery which actually improves the anatomical situation. So you try to increase, basically what you do, you cut the bone on several places, and you kind of flip the cup a little bit more over the femoral head, thereby increasing stability.
So basically, an arthroscopy is also in case of dysplasia, or as you said, a pincher or a cam. So basically, that in case there's a deformity of the hip joint, and there is wear and tear, in this case there's a tear in the labrum, it can be repaired with arthroscopy, but it does not necessarily solve the problem in the end, or can it be like an end?
Basically, when as a surgeon I see this plastic hip with a labeled tear, it makes me kind of cautious. Because the dysplasia itself can be a relative contraindication to perform the surgery. So it really depends on the situation. How severe is the dysplasia? How old is the patient? How big is the tear? Sometimes you should, and whether or not there is arthritis. If there is arthritis, there's no room for arthroscopy by definition. So
because then it's already past that point.
You can't repair the cartilage with an arthroscopic procedure. So if you have arthritis, really arthritis, then then there's really not much else you can do except replace the hip joint.
Okay, so basically the first step in the process with the wearing down is it always that you have a torn labrum before you have arthritis, or can you also have arthritis and your labrum still intact?
That's a good question. Actually, we don't know, because we don't have, if you have an arthritic joint, we're not going to do an MRI scan with intra-articular contrast to make the diagnosis. So presumably, I think it is likely that you will have a labral tear, but if there's arthritis, it's a bigger problem. So
if you have arthritis, then never mind the labrum. Okay, and if you have a torn labrum, it might be a sign that there is also arthritis or future arthritis, because it's caused by dysplasia, which might cause.
Yeah, usually you can detect it on MRI scan or CT, but it's not 100% conclusive. If you look in the joint, you usually can make the diagnosis properly, and sometimes we really are startled because we thought the joint would be much better than it actually was when doing the arthroscopy. So there is a room for arthroscopy in these plastic hips, but it's limited. And the surgeon should always wonder whether or not he should perform with the procedure or whether other procedures are more appropriate.
Okay, then that being said, when is the point that someone is eligible for a prosthetic hip? I know in some cases it can also be caused by an accident, but in our case, we're talking about wear and tear from life and from sports themselves. Of course, it's more of an exception to get this at a younger age, because it's usually surgery performed on elderly people, right?
Yeah.
Usually, yeah.
Well, you should bear in mind that a prosthetic joint is not a normal joint. It's not something which your body made, it's something which was made in a factory. And it's not something which belongs in the body. So the survival rates of artificial joints, although they are very good, are limited. If you look at the large register studies, we can see that after 10 years, if you look at total joint replacements, approximately 95% are still doing okay. At 15 years, it might be 90%. And after that, it will decrease. So if you're 38, in 10 years, you're 48, which is still young. And in your 50s, you might still be, you might need a revision surgery.
Yeah.
The revision cases are always worse than the primary hips, because you have loss of bone stock. Usually the muscles are not in good shape anymore. And this makes it very difficult to predict the effect. Usually revision surgery is very good for pain control. It will diminish the pain, but people might still keep a limp or some other problems. And it's always not as good as the first time. So that
is also the reason why it's always advised to postpone total endoplastic prosthetic surgery as much as you can.
And there's something else. We also know from the studies that if you are young and very active, your prosthetic might not last for 15 years, but maybe 10 or 8.
Okay, I have to put on the brakes with myself. Yes. Okay. Continue.
So for the midterm, it's a very good solution. But for the long term, it will give you some problems. Now, having said that, if the joint is so bad that it's really beyond repair, whether you wait 5 years or not makes no difference, because you were 38 when you had this hip joint replacement, correct? In 5 years, you would be 43, which still would be young for joint replacement. So at a certain point, it doesn't matter what your age is, it just matter what other complaints are. The youngest patient I ever operated for total joint replacement was a girl who was 19 years old. And so there are exceptions, but basically, if it's possible, if it's feasible, we try to postpone the surgery.
Yeah, and that's also, I said it before in a few questions that I answered, I tried to postpone it as long as possible, but for me, my daily life was affected, my personal life was affected, my work life was affected. I was basically living by whatever my hip allowed me to do. So that was for me the point where there was no other option. Postponing it didn't make any sense anymore. Okay, so because of course there are, I had a couple of talks with girls who told me that they talked to a surgeon, but they refuse or they don't want to do the surgery on them yet because they are too young. But as you basically stated, it should not necessarily be judged by age, but more about the situation, like the damage in the hip itself, and of course, how it affects someone's life.
There are certain parameters we look at, judging whether or not this patient is eligible for surgery. First one is the complaints. Like you said, if you feel limitations in your daily activities, and some people have pain at night, use a lot of painkillers, their walking distance is diminished. So those are important, but it should also match the X-rays. Because if the X-rays are absolutely normal or almost normal, even if you should have these complaints, no surgeon is going to do the surgery. Because you're not sure whether or not it will actually solve the problem. But if you have the complaints and you have an X-ray which matches the complaints, then, like you said, age is a relative contraindication, but certainly not an absolute contraindication.
Okay, good. Then another question is in general, okay, because I feel that so far with my personal recovery process, I'm still limited, for sure, mainly in my hip flexor seems to still be weak and not very happy with a lot of things I'm doing. Middle splits I can already do. I already use, of course, always active flexibility. So I support every position with all my muscles. I don't do any passive flexibility. But even though my recovery seems to go very well, this is not the case for everyone. So what is like let's say the how do you say Durchschnitt,
average.
the doorsnee, the average expectation after you have a normal hip prosthetic surgery?
Well, it also depends on the starting point. If you start with relatively strong muscles, like in your case, your rehabilitation time will be shorter than if you would have many years complaints, would not have been able to participate in sports. The muscles will respond to that by diminishing, and it's a long way back. I know from my own experience that almost a year after I had my joint replacement, I did this CrossFit training, and I used to do a single leg press. And although I could not find any variability in my daily activities, I felt both legs were just as strong, also in cycling, felt no difference. When I tested the legs separately, almost a year after the surgery, it was still weaker. So the rehabilitation time will take considerable. You will be able to perform normal activities relatively soon, but to be really up and running to maximum, how do you call it, performance, it will take some more time. So patience and diligence and discipline in your training should do the trick.
Yes, and as you already mentioned before, strengthening is key. Of course, in the recovery process, before it doesn't hurt, because I mean, officially, it's not like necessary to have a training regime before you go into surgery. But of course, a very strong body, especially glutes, abductors, like the whole hip area, is going to help with this. Yeah. Okay. And normal recovery time. Okay, I am now a little over 2 months past surgery. I had one setback, which set me back about a week. After 6 weeks, I slowly started moving again. For me, it went relatively fast. But I can also for sure say that I have still very strong limitations. I just learned to work around them. And I also
just to
really feel that my leg is still weaker.
But just put things in perspective. A lot of people, also if they had the kind of surgery you had, still use crutches after 6 weeks. Not everybody, but a lot of people do. So if you are at 8 weeks able to do the exercises you are doing now, you're not relatively fast, you are extremely fast. I showed your video to a colleague of mine who also does this surgery and asked his opinion, and he almost fell from his chair when he saw it, and he said, "I wish I had operated her." So your rehabilitation is not standard. Okay. So I think normally you would say the point you were at 6 weeks. Normally people would be there maybe 4 months, something like that. So it's important not to have the expectations too high, because you will get frustrated. You should be aware that there has been surgery, and even if it's a muscle sparing technique, you always damage the body. Every time you put a knife in a human being, you cause damage, always. So the body needs time to repair it, and the muscles need time to recover. And those are biological processes, and they just take some time. So patience and working diligently, but not overdoing it is basically the key.
Yeah, something I also learned very fast, which I will answer in my personal experience, like the part where I discuss my personal experience. But I think it's also important to stress that maybe my recovery is not standard, because before other people expect the same kind of recovery process that might be unrealistic. Also what was very clear for me is I had very low expectations. I was already, for me mentally, I had already basically made my peace with maybe never being able to do any splits again, or just very limited, which my front splits are still not there yet. So I guess before someone starts surgery, they should really also be able to possibly close that chapter, or really make sure that their expectations are not too high. That, like you always say, it will never be the same as before, and people should not expect that it's just like a miracle cure. It's a solution to a big problem, but it is not a miracle cure that's going to make everything.
Basically, the goal of the surgery is to make a patient perform his daily activities in a normal way without pain. It was not developed to do very intensive sport activities. So in the last decades, that has shifted. So people are pushing the barriers. But you should always be aware that it's not a normal joint. It is a prosthetic joint. The joint by itself is at its best the moment it's put in the body. From there, it will only deteriorate because you do have wear and some particles if you use it very extensively.
Yes, I think this is also important to know. And also for me, it is something maybe did not just completely click yet because I'm still working towards what can I do again. Is that there's also definitely a wearing down of the prosthetic hip. And you also maybe in the amount of activity that you do, you should also dial it down.
And the materials of which these prostheses are made are very, very well developed. And they've been improved every time and every time. But as an example, I had a patient who, an elderly patient, by the way, in his early 50s, who was training for a triathlon. And then he had the surgery. And after that, he still went on running marathons and cycling and stuff like that. In 8 years' time, the joint was completely destroyed. So we had to do a replacement surgery, which resolved his pain problem, but his sport activities were, his sport career was completely over.
Yeah. I am internalizing this information because I guess that's something that might slip my mind every once in a while when I'm like, okay, but I have no pain, so I can continue. But still,
you don't have to walk on eggs, so to speak. Yeah, you can actually.
For the Dutch people, this is a funny thing. This is a funny thing. Everyone else does not understand this expression. We don't have to walk on eggs.
They understand them. There you have to look for the fine balance. So if you do the flexibility, first of all, it's important the size of the femoral head you have, because if you have a larger femoral head, there are certain standard sizes. They used to be 22 millimeters, then they changed to 28, which has been standard for many years. And then they came with 32 and 36. 36 is usually, 32 is mostly used nowadays. If you're looking for a flexibility, a larger femoral head is better because it will give you a better mobility in the joint. The downside of the larger head is that it's more vulnerable or more prone to wear because you have a larger surface. So there's a downside to it. But if flexibility is very important, you should discuss it with your surgeon, and I'm sure he will make some recommendations to that effect.
Okay. Good. Well, then I have some questions asked by my followers. 1 second. Okay, so I would like to ask you a few questions asked by my followers, starting with question of Kate B. Is it hereditary or can anyone have this happen like an accident?
No, it's not like an accident. It has some hereditary components, meaning that if it is prevalent in the family, you will have a higher chance. But it's not hereditary. It means that it will follow the laws of.
You don't necessarily get it if your parents have it, so to speak. And it's not something you can get by accident.
No, you can't get it by accident. No.
Okay. Someone asked me if I am at higher risk for anything now, like arthritis. Well, arthritis, obviously not, because that was the problem. But I am at higher risk of luxating the hip, which means popping the prosthetic out of the joint, right?
If you would make excessive movements, yes. And the other thing is that if you use it excessively, it might give some particles, some wear, and the body may respond to that by making bone tissue becoming thinner. So the bone might disappear in part of it in extreme cases.
Okay.
So in the revision surgery, we often have to restore the bone stock, as we call it. We use bone transplant to restore the bone stock.
Okay.
But that is on the long run, not on the.
Okay. So like in general, like the main thing I am at higher risk of now would be luxating the hip. That's the biggest.
Yeah, and if that happens, you would have a problem, because then if you have it once, a late surgical dislocation, you might have it several times, and that might also be a reason to do revision surgery.
Okay, try to avoid that. Okay, someone, Zazu, writes me, thanks for your story. I also have a labral tear. What does doctor thinks your long-term outcome is? So I'm guessing, I'm not really sure how to answer this question, because the labral tear has been absolutely solved with the prosthetic hip. And the long-term outcome is what we already discussed with
but if the labral tear is the main problem, then arthroscopic surgery might be a solution.
Arthroscopy. Yeah. Okay. Then another question: long-term mobility, arthritis in the other hip, and dance ability. Well, arthritis in the other hip, we already established that it's also there. It's just not as in a stage as progressive as this one. So eventually, it's very likely that I end up with a prosthetic hip on the other side as well. Long-term mobility, I guess, depends on the training I do and the stability of my hip joint by the strength of my muscles. No?
Yeah.
Okay. This is questions for me. Interesting. Lisa Leaks asked me in German, hat die kaputte Hüfte was mit deiner so guten Beweglichkeit zu tun? So she basically asked me if my dysplasia is related to my range of motion, which you already discussed a little bit.
Yeah, if you have dysplastic hip, you might exceed your normal limits. Dysplasia gives you flexibility, but if you overdo it, you might damage the joint.
Well, it wouldn't necessarily give me flexibility, but it would allow me a greater range of motion.
Yeah.
Okay.
But range of motion is determined by many factors. One of them is the anatomy of the joint itself. The second one is the capsule and the ligaments around the joint, and then you have the muscle. So it's a combination which determines the flexibility of a joint.
And of course also the benda ligaments. What's it called? I don't know in English. The base.
Yeah, the tendons.
Tendons.
Tendons and ligaments. Yeah.
So Claudia from Chart Photography asked me if I was born with hip dysplasia. Yes. And you cannot increase dysplasia by flexibility training, right? It's only that the flexibility training in combination with the dysplasia can cause severe arthritis, which is the wearing down of the
arthritis and instability.
Okay. This is someone else asked Dr. Thala, when did it also from me? No. Sigues incapacitada.
Sorry?
I don't speak Spanish. I was hoping you did.
No.
Okay. I'm going to have to. Did I have any trouble with luxation so far? No. This was managing with exercise. Is there any kind of exercises people can do to manage the situation? well, that we are basically already established that it's basically strengthening all the muscles that surround the hip joint, which are glutes, abductors, hip flexor also, I would guess.
Yeah. But
Adductors, of course, also.
Buttocks, mainly abductors, buttocks, and yeah.
Okay. Are there any or many long-term limitations, especially regarding flexibility training? I guess that's something I will have to find out.
Don't overdo it.
Yes, thank you. Do you need to change the prosthetic hip in X years? Yes, approximately 15 to 20, as I understood.
Yeah.
If I would use it normally,
15 to 20 would be long. 20 years, if we see a patient with 20 years total hip, we are very happy. So 10, 15 years is something you can expect. 50 years is good, but usually patients will start having complaints after that period.
Okay. The other question from the wild blue yonder, are both hip dysplasic? Yes. These are also. Knoopjana asks, any tips for preventing or delaying surgery when having hip dysplasia and loving flexibility training and pole?
Discuss it with your doctor. Because sometimes you can prevent arthritis by what we call hip sparing surgery. And that depends on the situation. So if you have a dysplastic hip and you have complaints, always consult your doctor and discuss with him the possibilities and the impossibilities of treatment and also of your activities.
Okay. Question specifically, more specifically for you. Teresa writes, wird es möglich sein, nach einer Triple wieder Polesport zu betreiben? She asks, is it possible after a triple? I don't know what a triple is.
A triple is the osteotomia discussed, in which they actually cut the bone of the pelvis and actually shift the pelvis. I think so, yes, but it depends on the position of the joint and the way it has healed. But basically what you try to do with a triple osteotomy is to restore the normal anatomy. So basically making the joint more stable and giving it a larger surface to prevent arthritis. So if the triple has healed well, then you should explore what your boundaries are.
Okay. Okay, but in theory, yes, it could be.
Yeah.
Okay, this is probably more a question for physical therapists. Sarina Dutte asks me, wo kommt das Klicken in der Hüfte her? Yeah. Is das, weil passive Flexibilität größer ist als aktive? So hip clicking, so to speak, or what causes it? Yeah. And is it maybe because the passive flexibility is not supported by the muscles?
Yeah, well,
so that the passive flexibility would be greater than the active.
Yeah, if you feel clicking long after and short after surgery, it's okay because
no, without the surgery. I know she has clicking hip without surgery. Yeah.
Okay, well, clicking can have different causes. Basically, there are three main causes for clicking in the hip joint. It can be outside of the hip joint, on the outside of the hip, which is called a snapping hip. Basically, it's a tendon problem, and you can also have a tendon problem on the inside of the hip, actually in the groin, which we call a coxa saltans interna, so to speak with. Basically, it's a tendon problem, but also a labral tear can cause a clicking sensation.
Okay.
So those are the three main causes for clicking of the hip.
Okay.
And they're not all that serious. Tendon problems might not be a real big issue.
Okay. Strengthening the hip flexor, would it have any positive effect on clicking hip?
Yeah, depends. If I was talking about the internal click, that's the hip flexor, the psoas tendon. which has a close anatomy to the pelvic rim. So it might actually snap from the bony surface, which can give the snapping sensation. So sometimes physiotherapy might help.
Okay. Yeah, and she also asked, kan man auch mit Hüftdysplasie leben und was hilft? So it's also possible to have hip dysplasia without actually having to need surgery.
Yeah. If you have no complaints, and you have hip dysplasia, then we will do nothing. But if
so basically, in that case, keep the muscles strong and
but we will not intervene. But if you start having problems, then you have to intervene.
Okay. Connie Smit, hoe lang gaat een kunstheup mee? Heb nu pinnen, maar weet dat ik ook ooit moet. Ooit ook moet. Dus iemand met pinnen. Also she has pins in her hip, and she's wondering. She knows she's need a prosthetic hip, but how long the hip lasts, we already discussed. It's depending on the usage.
We tell a patient 10-15 years, basically.
Yeah. Okay. Another question specifically for a surgeon. What are the moves surgeons wished everyone did, especially when sitting a lot? I don't think sitting is necessarily related to hip arthritis, no? Or arthrosis.
No. Yeah. Usually the body needs to move. The body is designed to move. But if you have a problem with one of the joints, you should be moderate in what you do. But don't just sit on the chair.
Okay. Knoepjana also asks, how are the healing opportunities with surgery on both sides possible to change flexibility ever again?
On both, I don't understand the question, I think.
I think what she means is what the chances are of training flexibility if you have dysplasia or prosthetic hip surgery on both sides.
Basically, it's the same, but you are a double risk, so to speak.
Yeah.
And once again, yes, you can exercise, you can do flexibility training, but don't overdo it. If you're doing a split throughout the 180 degrees, it's asking for trouble. And whether or not this trouble will occur depends on the muscles, depends on the tendons. It also depends on the size of the femoral head, as I discussed, and it also depends on the way the prosthesis is placed inside the bone. Sometimes they use a little bit more angle like this, and those are all things that might affect the flexibility. Okay, so no oversplits with prosthetic hips. Yeah.
And the last question I have for you is, what exercises are best for us to protect our body from injury besides pole? So basically, what other training should you do to prevent your body from being injured from like hip injuries? Okay. It's basically the same, no?
In general, if you're in good shape and you have good muscles, it's the best you can do. And once again, do not exaggerate with the flexibility. Flexibility is good, it's important, but there are boundaries to what you should do when you.
Yeah, there's also flexibility to with different purposes. Okay. Yeah. Okay, so that's it with the questions. I think that was already a very, very helpful. So first I want to say thank you very much for taking your time and to share your expertise and your knowledge and your experience with us. I know there's a lot of people who have questions, and I'm pretty sure they'll be very happy to have as much information as they can directly from the source. So that being said, thank you very much.
You're very welcome.
And see you soon.
Okay, thank you. Bye-bye. Good luck.